Pancreatitis. Many things can cause trauma or injury to the pancreas, including alcoholism, gallbladder disease, hypertriglycerides, viral infections, ulcers, cysts, and abscesses, metabolic disorders, certain drugs, vascular diseases, and sometimes surgery of the pancreas, stomach, duodenum, or biliary tract can cause pancreatitis. Autodigestion of the pancreas is one of the most common causes, which can be from activation of the pancreatic enzymes in the pancreas rather than in the intestine. This can be caused by a backup from the ducts, which can be from an obstruction or by other means, and therefore causing pancreatic ischemia and inflammation. There's an acute and chronic pancreatitis, both of which can cause organ failure, pancreatic necrosis, and septic complications. The most common cause of chronic pancreatitis is the inflammation of the sphincter of Oddi with gallstones. Clinical manifestations include abdominal pain, usually located in the left upper quadrant, but may also be present mid-epigastrium. This pain has a sudden onset and is aggravated by eating and doesn't subside with vomiting. The pain is due to distension of the pancreas, peritoneal irritation, and obstruction of the biliary duct. Other manifestations may include nausea, vomiting, low-grade fever, leukocytosis, tachycardia, hypotension, and jaundice. Vowel sounds may be decreased or absent along with abdominal distension and tenderness. Lungs are often involved with the process, and crackles may be audible. Gray-Turner sign or Cullen sign may be seen related to seepage of blood-stained exudate from the pancreas in severe cases. The abdomen and flank areas may appear bruised due to the intravascular damage from the early activation of trypsin. In chronic pancreatitis, steatorrhea may be present as well as weight loss, malabsorption, jaundice, and a burning cramp-like pain.
When pancreatitis is present, serum amylase and lipase are typically elevated because they are released from damaged pancreatic tissue. These two elevated serum labs are considered primary diagnosis for pancreatitis. Liver enzymes are also increased due to pancreatic tissue damage. Elevated triglyceride levels by binge drinking of alcohol, hypothyroidism, kidney disease, and certain inherited lipid disorders can trigger inflammation of the pancreas. When pancreatic tissue is damaged, its cell contents are released, including glucagon, causing hyperglycemia. The level of bilirubin in the blood may increase if the common bile duct is blocked. Decreased calcium levels is an acute pancreatitis complication related to hypoalbuminemia and calcium binding to excessive fat.
The main goals of collaborative care include relief of pain, prevention or alleviation of shock, reduction of pancreatitis secretion, correction of fluids and electrolyte imbalances, prevention or treatment of infection, and removal of the precipitating cause if possible. Conservative therapy. Pancreatitis usually causes severe pain in the left upper side of the abdomen. Pain is usually controlled with IV morphine and may be combined with antispasmodic agents. If the patient's O2 set decreases under 95%, O2 is usually supplied. Patients are also made NPO to reduce or suppress pancreatic enzymes in order to decrease stimulation and allow the pancreas to rest. Shock may occur with pancreatitis. If shock does occur, patient may be given plasma or plasma volume expanders such as dextran or albumin. IV calcium may be given if tetany is present due to hypocalcemia related to hypoalbuminemia and calcium binding by excessive fat. Fluid and electrolyte imbalances may occur due to nausea and vomiting, or by NG tube suction used to reduce vomiting, gastric distension, and to prevent acidic contents from entering the duodenum. This may be corrected with lactated ringer solution. If severe enough, pancreatitis may cause necrosis and infection, which may be treated with antibiotics. Surgical therapy. When acute pancreatitis is related to gallstones, an urgent ERCP plus endoscopic sphincterotomy may be done. This may be followed by a laparoscopic cholecystectomy to reduce the potential for reoccurrence. Those with severe pancreatitis may require drainage of necrotic fluids collection. This is done either surgically, under CT guidance, or endoscopically. Percutaneous drainage of a pseudocyst can be performed, and a tube is left in place. Nutritional therapy. Initially, patients are made NPO. Depending on the severity of the pancreatitis, enteral feedings via nasojungal tube are initiated. When food is allowed, small, frequent feedings are given that are high in carbohydrates and low in fat to reduce stimulation of the pancreas. The patient must abstain from alcohol. Food intolerance is suspected if patient reports pain, has increasing abdominal girth, or has elevations in serum lipase and amylase levels.
Common medications listed here are either for acute pancreatitis or chronic pancreatitis. For acute pancreatitis, analgesics like morphine are used to manage abdominal pain, which is a prominent symptom of pancreatitis. The pancreas is responsible for producing bicarbonate ions and pancreatic enzymes like amylase, lipase, and protease. The purpose of antispasmodic agents like dicyclamine decrease the amount of bicarbonate and pancreatic enzymes that are secreted into the small intestine. Carbonic anhydrase inhibitors like acetazolamide, which is a diuretic, decreases the amount of circulating bicarbonate in the blood. It is secreted through the urine. Antacids and proton pump inhibitors like calcium carbonate and omeprazole are used to decrease the amount of gastric acid present in the stomach. For chronic pancreatitis, pancreatic enzyme products like pancreolipase contain all the essential pancreatic enzymes needed to break down food, and so this assists the patient in being able to absorb nutrients. Insulin is also used, as in chronic pancreatitis the insulin may be insufficient in producing the insulin to manage hyperglycemia. The adverse effects and side effects listed here are either the most common or they are life-threatening. For morphine, it includes confusion, sedation, respiratory depression, and hypotension. For dicyclamine, it's paralytic ileus, constipation, heartburn, and anaphylaxis. For acetazolamide, it includes depression, weakness, fatigue, anorexia, metallic taste, Stevens-Johnson syndrome, hyperchloremic acidosis, aplastic anemia, hemolytic anemia, leukopenia, weight loss, paresthesias, and anaphylaxis. For calcium carbonate, cardiac arrest, arrhythmias, hypercalcemia, and constipation are seen. For omeprazole, the most common is abdominal pain, pancreolipase, fibrosing copathy, and abdominal pain if used in high doses, diarrhea, nausea, and stomach cramps. For insulin, hypoglycemia and anaphylaxis are also seen.
Nursing diagnosis. Ineffective breathing pattern related to splinting from severe pain. Ineffective denial related to ineffective coping, alcohol use. Diarrhea related to decrease in pancreatic secretion resulting in cytorrhea. Adult failure to thrive related to pain. Deficient fluid volume related to vomiting, decreased fluid intake, fever, diaphoresis, fluid shifts. Ineffective health maintenance related to deficit knowledge, diet, alcohol use, medication. Nausea related to irritation of gastrointestinal system. Imbalanced nutrition, less than body requirements related to inadequate dietary intake. Increased nutritional needs as a result of acute illness. Increased metabolic needs caused by increased body temperature. Acute pain related to irritation and edema of the inflamed pancreas. Chronic sorrow related to chronic illness.
In this section, I am going to discuss potential complications that can occur with pancreatitis. There are two significant local complications that can occur with acute pancreatitis, which are pseudocysts and abscess. Pseudocysts is accumulation of fluid, pancreatic enzymes, tissue debris, and inflammatory exudates surrounded by a wall. Abscess, which is essentially a collection of pus. It results from extensive necrosis in the pancreas, and it may become infected or perforate into adjacent organs. As seen above, there are some distinct differences in the symptomatology between the two. For example,
Distinguishable symptoms of pseudocysts are palpable epigastric mass and abdominal pain, as opposed to abscess, which are upper abdominal pain, high fever, and leukocytosis. Other potential complications that may occur with pancreatitis are cancer and systemic. These complications typically arise from chronic inflammation of the pancreas or severe acute pancreatitis. In the next slide, I will be discussing preventive measures of these complications. Prevention of the complications discussed in the previous slide is very similar to the plan of treatment of pancreatitis, which includes monitoring and stabilizing vital signs, monitoring and stabilizing labs such as serum lipase, amylase, liver enzymes, electrolytes, and CBC, abdominal ultrasounds and CT scan, antibiotics, and reduced pancreatic secretions. The main priority of preventing these complications are reducing the inflammation cascade from the inflamed pancreas. If left untreated, it can cause systemic effects on the body and can make it prone to infections. In addition, other priorities to consider are lab values, because they indicate whether the condition is worsening. For example, elevated pancreatic enzyme amylase may indicate development of a pseudocyst, which may imply that uncontrolled production of pancreatic enzymes may be a contributor of the development of a pseudocyst. And lastly, abdominal ultrasounds and CT scans can assist in early detection of these potential complications, which allows early treatment such as antibiotics.